changes will do for you, how it's affecting you, how it's affecting your mood, how it's affecting your sexual desire, how it's affecting your body changes, how it's affecting your brain health. And so understand every aspect of the hormonal cycle that your body is going through. Learn to manage the stress that comes with menopause. And the last thing I want to tell you, if you feel like it's too much for you, you're overwhelmed, it's too far gone, and all the things we're talking about, that ship has sailed, get professional help. Ask your physician for a recommendation. See a therapist for 1 or 2 sessions just to help you through the transition, and make sure you have a support system. Ladies, there is no shame in menopause. Men, please support the women as much as possible. So thank you very much for allowing me to have this discussion with you. And I know we said questions at the end. If there's any one quick thing I can answer, because I might not be here at the end, I'll be very happy to. Any questions? Okay, I guess not. Well, thank you very much for your time, ladies and gentlemen.
All right, thank you so much, Ms. Norton, for that very informative presentation. And I love the way how you put it. Whether we're ready or not, menopause is going to come. All right, thank you so much for the beautiful checklist that you've provided us and how to reset our mood. Also, I love the way how you put it as well when you said, engage in mindfulness and how we can connect with ourselves once again. Thank you so very much. And thank you again for having this discussion with us today. Our next presenter is our very own Mrs. Dorothy Graham Charles, our nutrition manager here at Medical Benefit Scheme, sharing with us a healthy guide for basic nutrition when dealing with menopause. Join me in welcoming Mrs. Dorothy Graham Charles.
Good afternoon, everyone. Thank you, Ms. Defoe, and thank you to the prevention team for allowing me to be part of today's presentation. If I may be permitted to share my slide. So I've been given 15 minutes to present, and we have a whole conversation going on here when we talk about nutrition and menopause, but I'll try to summarize as much as possible. So forgive me if the presentation is not as holistic as you probably will expect, but we can always continue this conversation in the future. So let's move right along. We're going to talk about 3 basic concepts here this afternoon: nutritious foods for menopause, managing comorbidities, and additional points about fertility. And this is all in relation to nutrition. So let's talk firstly about climacteric changes. What are they, or what is it? It's the point in life where crucial changes occur, and this refers to the loss of reproductive activity marked by, not just for women, menopause in women, and reduction in testosterone production in men. So, as was mentioned before, it's all a natural part of life. It's a rite of passage. And how I like to phrase it, it's just a different season. It's a new season, and, just to embrace it as it comes along, and for us to navigate this season that we're going through, or those who are experiencing it at that point in time. So some of these changes that would be experienced during menopause are the symptoms. Symptom management is usually a big challenge for women. Bone density issues, such as the risk of osteopenia and osteoporosis, increased abdominal obesity, coronary heart disease, and onset of other age-related issues such as gut dysbiosis. So that balance between the good and bad bacteria. There's more bad bacteria than good bacteria as we age. And so let's say the risk increases. And so there's a whole management system for the gut microbiome as we age, and also cognitive decline. So those were mentioned earlier on, and some of the things that can be done to manage those. So you are given a definition of menopause, and you were also given a definition of perimenopause. So I won't take any time to go through those. You can see it there on the slide. Take a screenshot if you will. But just to move on to what we need to do to navigate menopause. And when we look at the nutritional management aspect of managing menopause, we need to manage the life cycle changes. And when we say life cycle changes, from the time a child is conceived right throughout their childhood, young adulthood, into woman or manhood, as they get into adulting experiences, as we call them, the work life, family life, and then, moving through aging, becoming elderly and having to deal with the nuances of that stage of life. So everybody is at a different stage of the life cycle. And so based on that disparity or that difference in the life cycle, we have to meet the needs of our where we are in the life cycle. So it may be that a baby will have different nutritional needs than an adult, as well as the hormonal needs will vary, and so based on the physiological, the biological needs, then the nutrition will have to be tapered accordingly. And so when somebody comes in for nutritional counseling and they may say that they have, they get a meal plan and they decide they're going to take it home for their husband or boyfriend or girlfriend or mother, sister, or children, it really can't work because we are all at different stages in the life cycle. And so we also need to manage the comorbidities, whether it's diabetes, whether it's thyroid issues, whether it's micromineral issues such as anemia or calcium issues. As persons age, their need for an iron would be less, but then there are still persons who may have increased need for iron. So we need to manage those. And then the symptoms, managing symptoms of menopause. And that can be a learning experience for everyone because not everybody is going to experience the exact same symptoms or the onset of those symptoms may not have the same causes. And so everyone will have to deal with the management system accordingly by checking in with their healthcare provider, their dietitian nutritionist, their therapist or mental health counselor. And there's nothing wrong with seeking a little counseling, Persons go and see the doctor, the lawyer, or the accountant. When it comes to mental health, oftentimes persons, especially in the Caribbean, shy away from that. There's nothing wrong about that. It's just getting back on that journey to better health. And then managing drug or herb nutrient interactions. So some persons may decide they don't want to take the hormonal therapy, and so they may seek to use herbal supplements, or they may want to take the prescribed hormonal therapy and they want to take the supplement, the herbal supplement at the same time. And there can be drug nutrient interactions. So they need to have a conversation with their physician and their pharmacist and other healthcare providers who would be able to advise and guide them accordingly so that there aren't any negative reactions or interactions that would make the situation worse off. And so when we talk about nutritional needs, as I mentioned earlier, the need for iron decreases as we get older and especially after menopause. So iron intake may not be a big issue because our body will tend to store iron more readily than if we were younger. If persons are experiencing low hemoglobin, then of course they can have that conversation with their primary care physician and their healthcare provider. But calcium is the main issue when it comes to menopause. So after menopause, leading up to and after menopause, there is a decline in calcium and bone mineral density. And so we need to ensure that our calcium intake is between 1,000 to 1,200 milligrams per day. And you can always talk with a dietitian and they can meter that out for you with a meal plan. Protein intake should be 0.8 grams per kilogram of body weight and following a balanced diet. So persons who really aren't hitting the gym or doing any intense workout, 0.8 grams of protein per kilogram of body weight is fine for that individual. And just to give an idea of what a gram looks like, a gram of protein, you would find that, let's say you'd find 7 grams of protein in an egg or an ounce of chicken or fish or any other protein foods like beef and pork, so forth. So that's just to give you an idea. That can be calculated by a dietitian. However, persons who exercise more regularly, they go to the gym, they have more intense workout regimen, then a protein intake of 1 to 1.2 gram per kilogram of body weight is usually good enough. Higher amounts of protein there is not beneficial to the body. Of course, there are various risks involved, such as impact to the kidneys. So too much protein is not good for the kidneys, as well as too much protein is not good for bone health. And so the body has this way of balancing out the nutrients once we take in the recommended daily allowance as guided by our nation. And again, each nation, they have different eating habits, such as Antigua. We have the Antigua black pineapple representing the food-based dietary guidelines. You can Google it, the Antigua and Barbuda food-based dietary guidelines, and based on household interventions done way back in 2013, and also various focus groups from workplaces and other institutions and organizations, they were able to make recommendations for the nation based on those consultations. Vitamin C intake is also very important. So what's in season now? Soursop is in season, mango is in season. You may be able to get a few Bajan or West Indian or Antiguan cherries, monkey apple or Malay apple is in season. So we have quite a good bit of vitamin C rich foods in supply. And so take advantage of those, especially those that are locally grown, locally available, because it's coming from our backyard. There's less production taking place. It's more natural and it's more readily available. Vitamin C is necessary for bone formation due to its role in collagen formation. And absorption is about 80% if the intake is 100 milligrams per day. So keep in mind, not all the foods that we eat are absorbed 100%. That's why it is important that when we have our food, whether the food prepared, cooked, raw, juiced, salads, that we are having adequate amounts to cover us daily, and especially at the point of menopause, because now our nutritional needs have changed. Now, vitamins and trace elements are very important because they act as cofactors in melatonin synthesis, which is, and I will mention them, folic acid, vitamin B6, B12, magnesium, and zinc. And these are very important cofactors because they aid with increasing the melatonin synthesis, which is necessary for good sleep. That's important. And there was a point made about the social media, the devices that we use, our phone, or tablets, or computers. It's important to switch them off early in the evening. And when we say switch them off, not turn them off in case there's an emergency, but to put them aside from our bodies. And that blue-ray light, it does have some negative impact in terms of melatonin production. So that's important. Sunshine exposure is also important. I'm going to talk about that in a little bit. So when we talk about the nutritional management of for persons experiencing menopause, it's important to eat adequate amounts of fruits and vegetables, high fiber foods, and when we say high fiber foods such as whole grains, fruits and vegetables do have high fiber as well. And keep in mind, not one particular food will give you all the nutrients. That is why, based on the Antigua and Barbuda food-based dietary guidelines, we encourage persons to eat widely from various food groups daily. And not just eating widely from various food groups daily, but also encouraging persons to eat different colors of fruits and vegetables. So the greens, the red pinks, the yellow oranges, the blues, the white and brown. It's important to have different colors every day. And many times in our circle, and we find now, especially with the newer generation, they tend not to like the leafy greens. And it's very important that we incorporate those into our diets, not just waiting until persons get to a health crisis, but instilling these habits in our children very early. And there are some foods that they may not like readily, but that is okay. We usually encourage persons to give several tries, right? And several ways of introducing certain foods. So we may not always need to give them spinach chopped up on a plate, but it can be well chopped up is one way of doing it. So with other vegetables, pepper pot is one way of doing it, a smoothie. So dropping a few spinach leaves in the smoothie. And there are other leafy greens that we incorporate in our diet. So, just to be versatile and adventurous in how we prepare our meals. We need to include calcium foods, and dairy is a rich source of calcium. So yogurt, low-fat milk. But there are other plant-based sources such as leafy greens, as mentioned before, beans, seeds, and provisions. And then our protein sources, and we are familiar with the meat sources such as lean chicken, fish, beef, pork, lamb, and you can name them all. But we also encourage persons to incorporate plant-based sources of protein such as beans, peas, lentils is a form of peas or beans, however we want to term it, but incorporate those into our diet. And something such as hummus can be used to enhance the flavor and the taste and the nutritional value of some of our meals or sandwiches or wraps, or even our what they call the Buddha bowl, a nice mixture of grilled and fresh vegetables and plant-based foods, which is very healthy and easy to make and easy to work with. And also heart-healthy fats are very important, so our extra virgin and cold-pressed oils, having unsaturated fats such as avocado, that's a very healthy fat, olives, and the extra virgin oils, peanut oil, peanuts, peanut butter that does not contain trans fats or hydrogenated fats. And there are other types of nut butter, such as almond, cashew, and the list goes on. Even tahini, which is used to make hummus and other healthy food items. So if we follow the Mediterranean diet, and we are already using it, it's just to use more of these and incorporate it in our foods. And we already use them in our local foods. So you should be able to get the nutrients you need from a healthy, balanced diet. However, a vitamin and mineral supplement may become necessary. So you always need to have that conversation with your healthcare provider, do your regular checkups, and we encourage persons to visit your primary care physician once a year at least. If you have a comorbidity that you're dealing with, such as diabetes, hypertension, thyroid issues, then you may need to go a little bit more regularly. And so your primary care physician would advise you how often you need to go. There is a schedule that we need to follow, and especially when it comes to like kidney disease, diabetes, there's a specific schedule. Sometimes the schedule may say 2 months, every 3 months. If there's a heart issue, maybe more regularly, because depending on what stage you are at in terms of the disease progress and treatment pathway, then they would be advised accordingly. I also encourage persons to follow up with their labs, and usually when they come for nutrition counseling, and we don't hold it against them, they just don't know. But it's important for us to understand that as dietitians and nutritionists, we need to see numbers. So saying that they did their last labs and the labs were good really doesn't suffice alone. We need to see exactly what number did that individual get. So for example, the cholesterol was good or it was normal, but as you know, the cutoff is 200. It should be less than 200 milligrams per deciliter. What if it was 197? You see what we're saying? And so you don't want to wait until it reaches 200, 210 to start doing something about it. Once it gets near to the cutoff point, we need to have our intervention going early enough so that you can be taken care of. So we like to see numbers based on your lab results, and so we usually ask for those. Now, healthy eating is very, very important, and we've been talking about that. Taking nutritional and or herbal supplements as needed. Now, everybody's going to need a nutritional supplement. So everybody's not going to need a multivitamin. Not everybody's going to need a herbal supplement, but you would know what symptomatic changes you're experiencing. And when you share that with your primary care physician, your healthcare provider, your dietitian, nutritionist, then they can help you resolve the issue based on your nutritional need that would have changed over time. Water intake is very important, and water is the beverage of choice over sugar-sweetened beverages, over alcoholic beverages, and we can't stress this enough, especially during that time. It's important to decrease the intake of highly processed foods, the ultra-processed foods, highly sugary foods, and to ensure that we're not consuming alcohol. I'm going to mention something a little later on about alcohol, but alcohol can sometimes exacerbate the symptoms. So if you can stay away from it, kudos to you. And there are many other things in life that can give us that satisfaction and gratification that we may get from alcohol. Alcohol and ultra-processed foods, what they do. You know that song by Sissy, lift them up and drop them. You know that song? That's what the sugar and the alcohol does to you. Lift you up and drop you. And so if you can keep up with the healthy foods, especially carnival coming around, don't be afraid. You can play mass. You have your bottle. We get some water in there, squeeze some lime, a little Angostura bitters, and you're good to go. You know, top it up with some ice. And you don't have to feel afraid that you're the only one not drinking alcohol. And there are many other persons joining the bandwagon, especially with the feds now. And they have the what you call them, the no-heatos, N-O-heatos, that doesn't contain alcohol. Strength and resistance exercise is very important, and we don't encourage, let me put it this way, we don't want persons to start doing that when they're experiencing menopausal symptoms. Start early. Start your children early so that when they get to that stage, it's just becomes part of their routine and their structure. Strength and resistance exercise, it helps with our gait as we get older. It helps with our posture. It helps to strengthen the bones, right? And it doesn't necessarily make us bulky or look masculine, but it helps to maintain tone and just general sex appeal. You know, some persons were curvier in the day, and after the hormonal changes and walking through that season in their life, they'll mention, oh, I've lost my derriere, I don't have that shape anymore. They're probably not getting the compliments that they're accustomed to. Strength and resistance exercise can help to allay some of those cosmetic issues that you may experience, as well as increase bone density and maintain bone integrity. And then sunshine is very important, because with sunshine, it helps with depression. It helps to keep our bones strong. Sunshine helps with vitamin D metabolization, and vitamin D metabolization helps to regulate our blood pressure, also our cholesterol levels. So the sunshine is very important. And even when we talk about cancer management and prevention, sunshine is very important. Yes, it can cause a certain type of cancer, but once well managed, we are good to go. And you know what? We live in the Caribbean, and a lot of us don't get enough sunshine, ironically. So that is important. Socialization is also important, rest and relaxation in terms of managing our moods. So sometimes what happens, persons may want to come in, and is there a magic bullet or a silver bullet that they can take to prevent or, to deal with the stress and all of that. But then if we're not dealing with the foundational issues and we take a supplement, we may not get the results that we're looking for. So those are basic foundational tools that we need to implement in our lives. Apart from the healthy eating, we need to ensure that we're doing our strength and resistance exercises, sunshine intake, very important, socialization, rest and relaxation. And of course, I know Dr. Abbott will mention in terms of your pap smear. That's very important for women's health. And yes, the risk is lower at a certain age, but it's always important to ensure that you're going to your OBGYN to get that taken care of, because of course we want to take care of the risk of cervical cancer, prevent that or manage or deal with what other issues that may be looming in terms of women's health. So things to watch out for: try to be active, get up and get out. Because of depression, sometimes persons just may not be in the mood, tiredness, fatigue. Sometimes you may have time, but not the energy. Dealing with children and spouse and family and work can be challenging at times. But if you can get a partner that you can work along with, some persons tend to be more active in the morning. They have more energy in the morning, some more in the afternoon, some more at evening time. So find what works for you. Smoking is a no-no for sure. And as we mentioned, sugary and alcoholic beverages. Try to decrease the simple and fast-acting sugars. So let's have, the fruits, the sugars from the fruits, which are naturally bound, over added sugars that we'll find in drinks and cakes and cookies and so forth. We're not saying you can't have a cake or a cookie or anything like that. You can have your cake or your cookie, but that should be not the rule, that should be the exception. Sodium intake should be managed as well, especially if there's hypertension, and the risk of hypertension increases with age. Yes, a family history, but as we get older, we find that our blood pressure may not be as sharp as when we were younger. So we need to keep doing our checkups, getting our blood pressures checked, even like our blood sugar, log them. When we say log them, there are apps on your phone, you can put them in. You can write it on a piece of paper. When persons go to the clinic, they walk with the exercise book. They write it in. Any which way works, as long as you have numbers to share with your doctor so that they can help you make informed decisions. So it's not just one reading, you need a number of readings to share with your doctor. And based on those readings, they can help you make the decision accordingly. Remember, you are part of the healthcare team. Saturated fat intake should be decreased, and it should be decreased to less than 10% of the total energy intake. So what are saturated fat foods? Those are the ones that have a lot of grease on it, and it melts when they barbecue that. So the fat that you can see with your eyes, the ones that are solid at room temperature, those are the saturated fats. Those are the ones that make the food taste good, but those are the ones that are not good for us. So we need, not saying that you can't have saturated fat foods, but to decrease the intake to less than 10%, a dietitian can help you to put that into perspective. And just 2 notes I want to make about menopause and fertility. Each person, some persons is quicker, some persons take longer, some persons it happens earlier, and for some persons it happens later. And based on some nutrition books, they'll say that persons with a higher body mass tend to menopause later. Again, that is not across the board, but that can happen. Also, a history of early menarche, early menopause, late menarche, late menopause, and based on your family history. So many aspects come into play here. But we want to encourage you, if you're going through that season, we've heard of some stories where persons have babies at certain points. I mean, when it's done, it's just done. So we just want to encourage the women to maintain their folate intake. And usually what's recommended is 400 micrograms per day. So 400 micrograms per day, give or take. And so just peradventure, something happens, somebody has a baby at opportune time, just to ensure that there's sufficient folate in the body so that we do not end up with birth defects. Fetal alcohol syndrome is also another factor. No amount of alcohol is safe, and this is not just for those who may have embarked on the perimenopausal journey, but also those women, and I use this platform to share, women on a whole who are sexually active. No amount of alcohol is safe for an unborn baby. And so we want to encourage us, we can find other ways to satisfy and gratify that need for an alcoholic drink. We can switch out with some nice spicy add spice to our drinks. Some persons can add a little chili, cayenne pepper, can add some lemon, some like a little bit of bitterness, sourness, saltiness, spiciness. So whatever it is that you need to gratify, you can use those natural resources to do that. And so in summary, protein intake should be 0.8 to 1.2, depending on your physical activity level, half of which should come from plant-based sources. Adequate intake of calcium, vitamin D, vitamin C, and B vitamins. This is very important. Adequate intake of heart-healthy fats and proteins, as I mentioned, avocados, extra virgin oils, nuts, seeds. Those are healthy fats. Ultra-processed food and alcoholic beverages should be avoided. Fruit and vegetable provides vitamins, minerals, fiber, and other plant nutrients such as antioxidants to help protect the heart. And remember, the heart is also at risk during menopause. The recommended daily intake of vegetables and fruit is 5 portions. It may be more for some persons and it may be less for others, like children. And so when we put it into perspective, 3 to 4 portions of vegetables and 1 to 2 portions of fruit. A half cup of fruit juice or crushed fruit or vegetable, that's a portion. If you slice or dice like watermelons or strawberries, a cup to cup and a quarter would be a portion. So it varies. Remember that coconut water is also a fruit. Coconut jelly is a fruit, but the dried coconut is a fat, and that's a saturated fat. What I usually say though, even though it's a saturated fat, it's a plant-based source of saturated fat, but the coconut has therapeutic properties even for women's health. So that's all right. It's just the amount that we are taking in. Ensure that we're having fiber-rich foods, 30 to 45 grams per day, preferably whole grains. 1/3 of the amount of grain should be from whole grains. So if you're having your white flour or your pasta, your white bread, don't go through the day and you're having white flour, white bread, white white pasta, meaning made from white flour, and you're having white rice, but no whole grains. We need to have whole grains every day. Half the amount of whole grains we have from corn or oats or brown rice or whole wheat flour, half the amount should be from the whole grains. And so with that, I'd like to say thank you so much for allowing me to present this afternoon. Again, this is a big conversation, but we got it started. Just know that this is a journey for all of us, and it's just a season. And even if somebody doesn't celebrate with us, let's celebrate ourselves. Let's celebrate with each other, especially as women. Let's be more supportive, and let us be more empathetic, and understanding of the situation, even if we are not aware of all the information. And with that, I'd like to say thank you so much, everyone, for being here today.
Thank you, Mrs. Charles. I think we got even more time than we bargained for from you, but we appreciate you. Okay, our next presenter, our last presenter, I should say, but not the least, is Dr. Dane Abbott. He's an obstetrician and gynecologist, and he will be touching on menopause, of course, its signs, symptoms, and how to deal with it. If you can all join me in welcoming Dr. Dane Abbott.
Hello, can you hear me?
I know I can, yes.
Okay, can you see me?
Not at this moment, no, sir.
Okay, can you unmute me then from your end?
Okay, I can see you now.
Okay.
Yes.
Are you hearing me?
Yes, we can see, both see and hear you.
Wonderful. So we've heard about menopause, and menopause on average is around age 51, natural menopause. However, I've seen women having their periods up until their late 50s. What's important is to try and determine exactly when menopause is. And what we say, the definition of menopause is of natural menopause is when a woman hasn't seen her period for 12 months. So once she hasn't seen her period for 12 months, that's menopause. Any sort of spotting or bleeding after the menopause is considered abnormal. And that woman needs to go and seek professional attention to check and see the cause of any bleeding or spotting that she may have after she's gone through those 12 months without having a period. The most important thing that we worry about is whether she could have some sort of cancer. And when we're talking about cancer of the lining of the uterus or endometrial cancer is what can cause her to have spotting or bleeding after the menopause. It's not the most common thing, cancer. It's probably out of every 6 women who may have what we call postmenopausal bleeding, 1 out of those 6 may end up having cancer. So there are lots of other causes, to have bleeding after the menopause, such as polyps, such as a thin lining of the uterus, but we cannot tell what it is until that woman is investigated to find out what's the cause of that bleeding. So that's very important. Now let's talk about the transition period. The transition period is the period before menopause actually begins. And it can be anywhere from 4 to 8 years before the menopause. And the first thing that a woman may notice is that her periods may go off a bit. So instead of her periods being, lasting 4 or 5 days, coming every month, she may find that the periods come shorter. Instead of 4 or 5 days, may last 1 or 2 days, or the periods may be longer, lasting 7 or 8 days. The periods may be heavier sometimes, or sometimes can be lighter. And the periods can come more often, like 2 or 3 times a month, or she may start missing months before the period comes. And that's what we call the transition or perimenopause period. Some people call it a change of life because things are changing in her life as well. Or the climacteric period as well. Another thing that a woman may start to experience is what we call the hot flashes or hot flushes. They're interchangeable. And what that is it's an intense heat that a woman feels, and it normally starts somewhere in the chest area and rises up to the neck and into the head. And that intense heat can last for a few seconds to maybe a few minutes. That intense heat is because of the estrogen that the ovaries aren't producing anymore. There's a lack of estrogen, and there's a heat regulating system in the brain which is affected because of that lack of estrogen. As the woman progresses into the transition period, those hot flashes can become more severe and occur more often, to the point that it may actually occur once a day to maybe several times a day. And then they can occur during the nights as well when she's sleeping, what we call the night sweats. And she can wake up from these night sweats. And because the night sweats wake her up, she may find it difficult to go back to sleep. And so because of the lack of sleep, she's going to be grumpy the next day because she's lacking sleep. Another problem that women have is that the vaginal area, which is sensitive to estrogen and is less estrogen, that vaginal area becomes dry. So she starts having itching and irritation to the vaginal area. She may find that having sexual intercourse, she doesn't get as lubricated as she normally would. And so sexual intercourse then becomes more painful. And because of the pain and the thinning of the vaginal tissues, she may experience cracking of the vaginal tissues, where she may have tearing and bleeding, during sexual intercourse. So that's another thing that women can experience. Dorothy spoke about the osteoporosis. That's something that the woman can start having because of the lack of estrogen. The bones become porous, and so she can have problems where she falls and more liable to have fractures from falling. And that can happen in the back, in the hip, and in the wrist area. So those are problems that we see. Now, in terms of the hot flushes, because of the lack of estrogen, one of the treatments that can be given is estrogen. So you replace the estrogen that the woman doesn't have. Some of the older studies have sort of told doctors, hey, perhaps the risk of estrogen is too high to be used. The newer studies are showing that estrogen is probably safe and the risk associated with estrogen is not that high. And so when we look at treating patients, we normally look at the balance between risks and benefits. And what we're finding is that the benefits of estrogen use in most women would be much better than the risks associated with using estrogen. We know that estrogen can be associated with some women, what we call hormone replacement therapy. Even women use estrogen and you give estrogen alone, it can increase the risk of certain problems. For instance, giving estrogen alone can increase the risk of a woman getting endometrial cancer, which is lining of the uterus, cancer in the lining of the uterus. Can also increase the risk of some women having strokes and DVTs, heart attacks. But we've found that those risks are very low in most women. There's some women who can't use estrogen because they have comorbidities, but most women can use the estrogen, and the estrogen can in fact decrease the amount of hot flashes they have, decrease the intensity of the hot flashes they have, the frequency of hot flashes they have, and so it works very good. We can use other things such as, making sure that they're in a cool environment, making sure they use a fan, air conditioning, trying to use layered clothing so they can take off their clothes and not get as hot. But we know that estrogen is what's lacking, and we know that estrogen works very well in women who have hot flashes. So the new studies are showing that estrogen can be used, and it's probably more beneficial to use estrogen than not using estrogen because of the risk. With regards to the vaginal problem that women have, if it's only vaginal problems they're having, then local estrogen probably can be used. And there's a cream known as Ovestin cream, estradiol cream, which can be inserted on a nightly basis inside the vagina. And what that estrogen cream will do is thicken the vagina, make it more lubricating, so it's not as dry. So therefore, sexual intercourse doesn't hurt the woman, doesn't cause bleeding and pain as it would if she didn't use this estrogen. And so that's very good. In terms of osteoporosis, again, Dorothy talked about calcium, which is very good, and exercising, which is good. And so those are things which can be used to help with the osteoporosis. What I'm going to do, because I know that we're sort of running out of time, is probably ask if there are any questions, or if you just want me to continue speaking. So any questions? Anybody have any questions about the menopause and the transition? Hello?
Dr. Abbott?
Yes?
I missed something just now. You're finished?
Well, I was asking if anybody had any questions.
Oh, you asked it. Let me see if there's any question in. So far, I'm not seeing any question in the chat. Well, let me ask my question though. I would just okay. About the cream, would we say in terms of the male counterpart, is it something that would have a long-term effect on the man in terms of maybe some small amount over time inserting, going into the penis? Would that have, or is it known to have any side effect for him?
I haven't heard of any side effects. I mean, basically, what a woman will do is insert the cream inside the vagina, and the cream vagina moist. Very little of that cream would be absorbed by the woman. And so even if the man was supposed to have sex with her and there's some cream left in the vagina, it wouldn't really affect his penis. And not a lot of it would be absorbed by the penis. And so I don't think there would be a problem with the man having sex with a woman who's been using that estrogen cream.
Okay. Let me see something, if there's anything in the chat. Okay, I see somebody asking about, can you ask a question on vision issues associated with premenopause? I'm not sure if that's a question that would be for you, or maybe even a, I'm sorry, I'm having a senior moment with the word. Is it a, what do you call it? The eye doctor? I'm so sorry. Yes, ophthalmologist.
Right, what's the question? Sorry, I didn't hear the question.
Oh, you didn't hear the question, I'm sorry. The person asked, can you speak on vision issues associated with premenopause?
Vision issue.
Oh my, I'm sorry, perimenopause. My apologies.
Perimenopause. I mean, there's some women who might experience some dizziness, but I've never really heard of any woman having any problems with their eyes because of the perimenopause. But women do do get some dizziness sometimes from the lack of estrogen that they have.
Okay,
I mean,
so sorry, go ahead.
It can get worse, but the perimenopause itself, I don't think it's really contributing. to problems with the eyes. As you get older, that can happen.
Okay, so what I am thinking maybe for the person, if it is that is something directly with the eyes and they realize it might be, they definitely would need to
See an ophthalmologist.
check. Yes, yes, yes. Do we have any more questions that you guys would want to ask on the chat? Anyone else? I'm thinking what I realize with this topic and other topics, you know, in general, I'm guessing when it comes to health, some persons, I think we're afraid to ask questions, but we prefer, you know, one-on-one. So what I can say to everyone listening on this health talk today, if it is that you guys, you know, you don't want to ask the question via chat because you don't want the question read out, what we can do for Miss Norton when it comes to your mental health, for Mrs. Charles for your nutritional aspect of menopause, and of course, Dr. Abbott, we should be able to. I'm assuming it wouldn't be a problem for us to reach out to them.
Sure.
Reach out to them to I'm sorry. Sorry about that. That question just popped up. Someone asked, oh, they said they just joined in. They were asking if they can get pregnant during perimenopause.
Unfortunately, yes. So perimenopause means regular periods, okay? But sometimes you still may ovulate. So you may not ovulate every month with people who have regular periods every month. Because once you have regular periods every month, it normally means that you're ovulating every month. People going through the perimenopause, they may ovulate once every 2 or 3 months. But if they ovulate and have sex at around the time that they ovulate in, then they could get pregnant. So I've seen women pregnant at the age of 47, 48, because you know, they're going through the perimenopause, they miss the periods, then they find out that they're pregnant. So that can happen.
Oh my goodness, that sounds a bit scary for some in the end.
It's very important that as men get older, if they're still sexually active, that they need to use birth control. They need to use birth control because they can become pregnant.
Okay, I'm seeing the next question. One more question. I can't get to see. Yes, yes. Okay, the question is.
Good afternoon. I have one question just based on what you said, Dr. Abbott. So if it is that you recommend birth control, does it suppress your menopausal symptoms, and how would you know that you've started?
Well, I mean, there are different types of birth control. It does not necessarily mean that you have to use a birth control pill. So there are low-dose birth control pills, which can be used by perimenopausal women. And what will happen, will have regular periods every month with that. And she will probably have less symptoms of the menopause because she's getting the estrogen from the birth control pill. Normally, if a woman is taking birth control pill, I will tell her, keep taking the birth control pill until you get to 50, 51. Because like I said, the average age that women go through natural menopause is about age 51. And to be honest, in the past 30 years that I've been practicing, I've never seen a woman over the age of 50 get pregnant. So I normally tell my patients, once you get to 50, you can stop using birth control because you probably won't get pregnant. Once she stops taking the birth control pill, then if she starts to have symptoms, then she may be able to use like an estrogen or something to replace the estrogen that she's missing. But there are other forms of birth control. She can use condoms if she wants. She can use the IUD, the copper T IUD, you know, just to try and prevent her from getting pregnant once she's going through the perimenopause. So she doesn't necessarily hormonal birth control. She can use a non-hormonal birth control.
Thank you. I was speaking specifically to the pill because I think it still allows a period, and I was wondering how would you know that? And
So,
when you're trying to balance not getting impregnated at the same time.
if you want to use a pill, I normally tell you, keep using the pill until you get to about 50, 51, then you stop it. And if you start the menopause, then you use something else.
Thank you.
You're welcome.
Okay, there are two more questions. The first one, if you do not get a period because of the contraceptive that you are taking, how do you gauge the start of menopause?
Sure. So if you, for instance, on an injection, which is the Depo-Provera, a lot of people in the Depo-Provera will not have a period. And so what I normally tell them is that once you get to 50, 51, you can stop taking the Depo-Provera because you're not going to get pregnant. You don't need the birth control anymore. And then you may start to have symptoms of the menopause.
Okay, just the last question. What is the youngest age would you have seen in a person experiencing menopause, or at least symptoms of menopause?
Sure. So the average age, like I said, is about 51. Women normally, the range that normally women have is between 45 and 55 is when they go through menopause. If women have menopause before age 40 to 45, we call that early menopause. And then there's some women, not a lot, but a few women, very rare, that will actually go through menopause before age 40. And that's what we call premature ovarian failure or premature menopause. So we have seen women in their late 30s who have gone through natural menopause. Very rare, but it does happen. I mean, usually if a woman is in her 30s and she misses a period, then the first thing I want to find out is, one, is she sexually active? If she is she pregnant? If she's not sexually active or pregnant and she doesn't have a period, then we normally think of some sort of a hormonal imbalance that's preventing her from having a period. But if a woman is in her late 40s and she doesn't have a period, then, yes, I want to make sure that she's not pregnant, but then I start to think that she's going through menopause or perimenopause.
Okay, seeing one more question came in, Dr. Abbott. Is there a recommended estrogen supplement?
Sure. So what we have here in Antigua is something known as Premarin. And Premarin is what they call a conjugated estrogen. It's actually from pregnant horses. And so we can give Premarin tablets to women who require estrogen because they need a hormonal replacement. We also can give them something known as Provera, which is a progestin, similar to the natural progesterone, which is made by the ovaries. So those are things that we can give, the Premarin and the Provera. Women who have a uterus, if you give them estrogen or Premarin alone, it can increase the chances of them getting uterine or endometrial cancer. So we have to give them estrogen and Provera to try and reduce the risk of them getting endometrial cancer. So that's what we probably would have to give somebody. If she doesn't have a uterus, then she can just get her estrogen alone.
Okay, thank you for that question.
Dr. Abbott, one follow-up question, sorry. Do you recommend staying on the pill to avoid full-blown menopausal symptoms? Since they have estrogen anyway?
It's a possibility because we do have low dose pills. And if the person doesn't have any risk factors, one of the things I tell women is that, you have to weigh the risks versus the benefits. And so if somebody is not sexually active and don't require birth control, I probably wouldn't tell them to be on the birth control pill just to avoid the risk of the menopause symptoms. I would probably tell them, stop taking the birth control pill because there are risks associated with that, and use something which doesn't have as much risk, which is the hormone replacement. Because the birth control pill has a higher dose of estrogen. So the higher the dose, the more risk you're gonna have. Whereas the has a lower dose.
Thank you.
Welcome.
Okay, I see another question here, Dr. Abbott. What about menopause that a woman has been plunged into due to surgery? So I'm assuming she's meaning you got surgery to remove, and you basically automatically
Sure.
directed or inserted into menopause?
So there are some women who may have an ovarian problem. They may have an ovarian cyst, for instance, and they have to be bilateral because we have two ovaries. If only one ovary is removed, then the other ovary will work and she will not go into menopause. But if she has both ovaries removed, for whatever reason, then she will automatically go into menopause right away. And so those are women who will need to have estrogen replacement therapy to try and help the symptoms that they will be experiencing after having both ovaries removed. I saw somebody saying something about hysterectomy. So a hysterectomy means we just take out the uterus. And most times, if the person is young, and when we say young, we're talking about a person less than 50 years of age, in maybe less than 45 years of age, we tend to leave the ovaries in those persons because those ovaries will continue to work for a few years and will prevent them from going to the menopause, what we call surgical menopause. They will then go into natural menopause when they get to 51, 52, that age. And so those women who have surgical menopause, because we take out the ovaries, those persons will have to have estrogen replacement to help the symptoms that they're having from the menopause. So a total hysterectomy is where we take out the uterus and the cervix. So that's what we call a total hysterectomy, and we leave the ovaries behind. We can do what we call a total hysterectomy and BSO, bilateral salping oophorectomy, where we also remove the ovaries. And if the person hasn't gone through the menopause and we take out the ovaries, then that surgery will cause them to go through menopause, go into menopause.
Okay, thank you. We have a few minutes left. Any more questions before we unfortunately close off this chat for today? I think I was saying something before I started to read the questions. As everyone, all the speakers I think would have mentioned, each person obviously would have their different needs with regards to the menopause. So what we're recommending, if it is that you may have further questions, further concerns, guys or ladies, even the gentlemen who may be listening in, you see certain signs, you may not want to speak to her directly first because you might be afraid to get your head bitten off or your eye, bashed in. Just reach out to each of the individual, Miss Norton, Mrs. Charles, Dr. Abbott. I'm assuming that it would be no problem to make appointments with each person to get further information on the menopause, not just menopause, health in general, but as we're speaking on menopause today, I'll say that. And reach out to them, don't be afraid. It will be better for you guys to have a one-on-one session. Maybe you will have more questions to ask them, more concerns to hear. So just reach out to them and hopefully all will be well. You have a better idea, better understanding, especially the gentlemen, in how to help your partners deal with menopause, or how best you can help them to deal with menopause. I'm not seeing any more questions. So at this time, I think it may be safe to thank each and every one of our speakers today for giving us your time. And I know time is definitely very valuable. And we really do appreciate you guys. We really appreciate it. And thank you also for the participants for listening in today, for airing your questions and your concerns. And we hope to see you in our next health talk. So guys, you have a good afternoon. You have a closing question? Sorry. I'm seeing a question there. Any recommendations for menopause due to total hysterectomy? He didn't say something to that effect.
Have been removed and having symptoms, which they more likely would have, then she can In the hormone replacement therapy, yeah.
Okay, maybe that person wasn't in the chat at the time. Well, thank you guys so much once again, and I wish everyone who may be, venturing to their homes, please be safe, and we'll catch you guys on our next Health Talk. Have a
Thank
good afternoon.
Thank you very much.
Are you at work? Are you at work? Huh? How are you? Are you, hi, are you at work? Are you at work? Are you at work?
Miriam, Mrs. Richards, carefully, I'm hearing you. Everybody's hearing you.
I thought the meeting was finished.
A lot of people still online.